And thanks everybody for making time today. We know that you all are busy and certainly a different season in healthcare and in our world right now. And so with so much going on, we recognize that carving out time here for this is just a matter of trying to balance between so many things that you're working on. So still very important, obviously. And as we're closing in towards the end of the year, ironically enough, right, 5 months to go really before the end of the year and when these requirements will go into effect. And so many people as a result have had really a heightened interest in making sure that their hospitals are prepared for the coming disclosures. I know there were a number of folks too that were anticipating the result of the litigation case that was just ruled on just a couple weeks ago, actually, where AHA and others had tried to, essentially assert that hospitals should not be required to disclose a lot of the payment rates that are being required in the latest hospital transparency requirements. And, a judge ruled in CMS's favor. AHA is trying to appeal that decision on kind of a fast track. But again, I think many now in the industry with that decision are truly trying to make sure that that people are prepared. And so we want to turn our attention now to kind of helping folks get prepared for that. Just going to do a quick check. Is audio coming through okay? Mike, I see your comment.
Yeah, I can hear you fine. Just was hearing a couple comments from people that were having some trouble. So it looks like most of the people are hearing us okay.
Okay.
Yeah. Okay. Sorry. Go ahead, Jamie.
No, that's good. I thought I'd do. I saw your chat come through. I wanted to make sure that that the audio was coming through strong. So okay. So there are really three things that we want to do here today. One is describe the price transparency guidelines that will be effective on January 1st of 2021. List out kind of important action items that hospitals must implement, and then try to contrast the two different ways that prices must be published. So with that, whenever we have this conversation, I think it's really helpful to go back to kind of a transparency timeline to set the context for this. And what's really interesting is this call for transparency really goes back to its originating point in ACA. So back in 2010, there were these initial calls for transparency that were included in that legislation. Now, for several years, there really wasn't any movement or any feedback along kind of those lines. And so there was a reminder in the FY19 proposed rule that hospitals needed to be posting CDM-related information or providing some means for patients to gain access to it. And, with that, again, being more vague, we saw 4 years later in the FY19 Final Rule, and then follow-up kind of responses to frequently asked questions, a definitive requirement prescribing hospitals to make available a list of their current standard charges via the internet in a machine-readable format and to update that information at least annually. That sort of lived out there for about a year, and then the executive order from President Trump last June, June of 2019 rather, calling for even additional transparency policies and guidelines to be developed. And that contributed to what we now have today in front of us as the CY20 Final Rule on hospital price transparency that we'll get into today. The one thing I wanted to note here, because this has not received quite as much press here, but there really is kind of a doubling down of transparency. And we see that even yet this year in the FY21 proposed rule, Medicare is proposing to require hospitals to provide on their cost reports the median health plan specific negotiated rates for inpatient services by MSDRG. So there is, again, yet another kind of component of making this payment-related information public as well through the Medicare cost report. So again, the world keeps changing and changing very quickly with regard to the transparency requirements. We're going to spend, obviously, our time today discussing the final rule on price transparency. But again, did want everybody to at least know that that is being proposed so that, again, if you have concern or questions on that, opportunity time right now to make those known to CMS to the commenting window. Key dates for this, the current price transparency rule. There is a link here, and again, Mike had mentioned we will be sharing kind of the slides. So there is a link on your screen that will allow you to get to the source language through the Federal Register. There was a follow-up call on December 3rd of this past year to address key questions. And we'll be kind of sharing just a bit. We have learned from the CMS price transparency team that a responses to frequently asked questions is also forthcoming. So be on alert for that. They have said that they're going to make that available on the website and notify folks here in the next month or two. So again, be prepared for that document to come that could address some of the common questions that people have had with regard to this current rule. This is going into effect January 1st, 2021. In our discussions with the CMS price transparency team, it is not anticipated that there will be an extension. I know that's been one of the questions that have been asked, if there would be extensions on this given the pandemic and what that has caused for so many hospitals. Again, even as late as 2 days ago, I was told by the price transparency team that no extension is anticipated. I think it's always interesting to kind of look here too. This current language is really building off of language that has existed, and it's more kind of definitional in part in terms of trying to provide more information on how hospitals should be complying with that original ACA request. So if we look back at that language, really all that was requested then at that time was that hospitals make public a list of their standard charges for items and services provided by the hospital, including for diagnosis-related groups. So these key elements of standard charge and items and services, those have not changed at all. We're now just learning how they are defining those elements. So as it extended into kind of 2014, really the feedback then was, hey guys, you've got to be doing this, but we believe that you're in best position to define this and to format this disclosure as best as you feel kind of necessary and appropriate. 4 years later, again in the FY19 rule, they said, hey, you know what, we're going to provide a little bit more clarity here. We are wanting to see your standard charge. We want to see it posted to the internet in a machine-readable format, and we want it updated at least annually. So again, a bit more clarity, but they did even kind of specify then, but the format could be, again, in a format of your choosing. Now what we're seeing, again, is some definitions around how they want you to define items and services, standard charges, the format, and they also have kind of clarified who needs to be doing this by determining what hospitals need to disclose. So with that, let's kind of start to walk through some of these key kind of definition elements. On the definition of hospital, really, if you are not federally owned, you're subject to these disclosure requirements. So there was some ambiguity before around, gosh, I am a critical access hospital, or I'm a sole community hospital, and so if I'm not prospectively paid and there's this diagnosis-related group component, do I need to be doing it? Again, some ambiguity there that Medicare tried to address in the responses to frequently asked questions, but they have now put this into a rule. It's not just sitting out into an FAQ document. So Again, unless you're federally owned or operated, you've got to make this information public. They did specify that ASCs and other non-hospital sites of care are excluded, though, so that is of note. Kind of definitions on items and services. They have expanded this out. They're now requiring this to be all individual items and services. And then here's kind of a key term, service packages that could be provided by a hospital to a patient in connection with an inpatient admission or outpatient department visit. When we think about items and services, these are items in the charge master and or provided to patients, including drugs and supplies. Again, this was a piece that they had tried to address through an FAQ document in the last rule. They are now kind of putting it into an official rule here in this latest rulemaking. Service packages, this is new. So this is any type of an aggregation of items and services into a single service with a single charge. That the hospital could be paid under. So this would be things like MSDRGs or per diems. And if you're hearing this and going, wait a second, this doesn't sound like anything I would maintain in the charge master, you're absolutely right. And so we'll talk about this in just a second in terms of how they're now defining what that standard charge means. But these are really more payment-related kind of elements. The third piece in here, and this was a bit of a shakeup as well, and this is pro fees. Now, the requirement here is only if the physicians or non-physician practitioners are directly employed by the hospital. And so there have been some questions posted back to CMS about the nature of the employment. Again, many hospitals have a different legal entity that actually does employ the physician groups. And again, these even non-physician practitioners. And so the thought, at least right now, in terms of letter of the law, could be that those groups might not be subject to that. But again, this could be something that gets addressed in the responses to FAQs. And again, we certainly believe that consulting with your legal team or legal advisors on a particular component would be advisable. They have broadened out the definition of standard charge to include 5 different elements. The first one is what we've all defined as standard charge, and that is your gross charge for individual items and services that are reflected in your charge master. Again, absent any discounts for that. The other is your discounted cash price, and there have been some questions about this. Well, what's that mean exactly? So if you have a self-pay policy, or you do in fact have a true discounted cash price policy, these would be things that CMS wants disclosed now. This could be in the form of a paragraph if you'd like to disclose kind of what your discounting policy is, or maybe a scheduling kind of table of how you have different thresholds for cash prices based on either income requirements or so forth that could tie into your charity care policy. These are all kind of elements that could be defined in this element right now. The third through fifth all deal with your payment elements, and so the third one is the lightning rod one for sure. That is your payer-specific negotiated charge. This is what AHA and others were trying to fight in terms of disclosing because of the proprietary nature of that for privately negotiated rates. They did not believe that CMS had the authority to require hospitals to disclose privately negotiated rates. And again, a federal judge ruled in favor of CMS on that. So this would be the charge that a hospital has negotiated with a third-party payer or for an item or service, which brings into play kind of that element of a service packages, again, that they had alluded to in the previous slide. One thing to note, you'll see in red at the bottom of this slide, Medicare and Medicaid rates would not need to be disclosed as these are not negotiated. So again, that is a caveat there to consider. 4 and 5 deal with the de-identified min and max negotiated charge. So again, if you're thinking about like a DRG base rate, they would want to know what's the min for that base rate and what is the max for that base rate. But then again, for number 3, they'd want to see for Blue Cross, for United, for Aetna, if they have a DRG base rate, they want to see what that DRG base rate is for those payers. Or they want to see, again, potentially some derivation of that. And again, some of that information could be clarified a bit more in terms of formatting in the responses to FAQs. In terms of how they want these components published, there are 2 different formats that they are prescribing. The first is a comprehensive machine-readable file. The second will be a consumer shoppable component. We're going to start with the comprehensive machine-readable file, but again, very important to note that they both are requirements, and they are in fact 2 different components. So even though this first component encompasses all items and services, the separate consumer shoppable component is also required because CMS has recognized that there will be so much information here in this document that it is unlikely that any patient will be able to honestly make heads or tails out of it. And so they are requiring that a separate disclosure be made to assist with patients identifying those top volume shoppable procedures. And so I think the hope for this one is this machine readable file is that there can be folks in the IT kind of industry that will be able to essentially download these files and potentially use them for increased transparency in the industry. And so with that, the components that they are requiring in the machine-readable file, again, is that every hospital that's, again, not federally owned or operated needs to make this information available. It needs to be updated at least annually. It needs to be a single machine-readable file. Examples of that would be XML, JSON, CSV, but not PDF, and they were very clear about that. It needs, for data elements, to have a description of each item or service. It needs to contain all 5 standard charge types that we just discussed. With, in addition to that, any inpatient or outpatient pricing differentials. It also needs to include accounting and billing codes. Examples of that would be HCPCS codes, DRGs, or other kind of common identifiers. They also mentioned NDCs as a potential component for that where applicable. Location accessibility, it needs to be prominently displayed on the website without barriers for patients to access. So last year, as folks started rolling out their disclosures, some folks kind of put that disclosure behind a consumer kind of entry screen where a consumer had to provide an email address or some information to create an account of some type. CMS has said that you can't do that. It has to be available without any barrier for a patient to access. And the document must have a CMS naming convention that they've prescribed. Well, it must be one searchable file. The file could have multiple worksheets to display the different types of elements that are included. And this came out in the December MLN call. And so that's important, and we'll talk about that here in just a second. This is an example that's provided by CMS. You'll note that this is only for the standard charge, kind of the gross charge component of this. Again, probably most folks had an understanding of how to put this one together. They have informed me that they will also be trying to show alternative formats for the other components, but in the kind of communication that I've had, they have reiterated that it won't be a requirement to follow. What they will show as illustrations and they have said that they feel that the illustrations will be fairly, basic in terms of trying to illustrate these. So I don't know that we will have much more in the way of feedback for specific formats that will be required. Again, as they've said that the specific formats can be done in the hospital's kind of choosing. They did also say that this kind of ERX charge quantity was completely optional. Those did not need to be included at all. As we've thought about kind of this combination of elements, this is a matrix that we have put together that we have gotten really positive feedback on from CMS, and have also, have really had good feedback again as we've shared this with our hospital partners in terms of trying to illustrate how these different components either can come together or are not able to come together, which leads into that, again, item of these being disclosed in one file, but potentially if you think kind of in almost the Excel kind of mindset, and again, I know that the IT folks would recognize that these aren't necessarily Excel documents, but again, for probably many of us on the call, that's how we think of it, in being kind of separate worksheets or components within that one comprehensive file. So with that, let's kind of talk about these different elements. So on the definition of items and services, we now have on the hospital or technical side individual items and services. We have our service packages, which again would be that aggregation of items and services. And we also have our pro fees. On the definition of standard charges, we have 5 different elements, right? We've got our gross charge, our discounted cash price, then we've got our payer-specific negotiated charge, and our de-identified min and max of those elements. So if we think about the first kind of worksheet, it really is this gross charge at the service level. This essentially is probably what you're doing today. It's your CDM type disclosure document. There's now a couple additional requirements that are in there, like a HCPCS code, NDC where applicable, but again, more than likely, not too terribly different from what you're doing today. The discounted cash price. This one, again, is probably not too terribly cumbersome either. Again, this component could be a paragraph of your policy that you have for discounting cash prices for patients. Again, if that is something that you've established. You'll see on worksheet 3, we have a little plus sign. And the reason for that is when we think about the pro fee side, and again, for some of you or many of you, this may not be an element that you will be subject to disclosing based on how you employ your physicians and non-physician or practitioners. With that, you will have obviously a gross charge and potentially some type of discounted cash price policy for those as well. But on your payer-specific ones, if we think about the pro fee side of things, it's very HCPCS driven, right? So you could conceive of a situation where you could have your gross price and then your payer fee schedules all in one big document. With different columns going across for those different payer-specific negotiated charges. However, our thought is probably that for patients to be able to have easier access to this, and more than likely for there not to be kind of faulty comparisons potentially, it may be advisable to not have these different elements included in one particular worksheet. So, having your gross charge on one worksheet and then having your individual payer schedules for those on separate worksheets, again, probably could be advisable. You could then obviously have those existing for the de-identified min and max as well. The big piece here obviously is on the worksheet 4 and 4+, and this is all of your payer-specific negotiated charges. Again, more than likely, it would make sense to have those identified in different worksheets as well. 5 and 6, again, could be, again, having your de-identified min and max for those elements in there also. So again, if you've got that DRG base rate, you'd want to see kind of the min value and the max value for those elements. On the next disclosure document, so that was all the machine readable disclosure. This now relates to this second disclosure, and this is for the consumer-friendly shoppable services component. Again, every hospital needs to disclose this information and update it at least annually. The quantity, they are requiring at minimum 300. So 70 of these codes they are prescribing, and the other 230, they are allowing you to select. If you don't have one of the 70, they want you to backfill that. And if for some reason you don't have 300 that fit that criteria, you need to provide as many as you can. The selection for this, a shoppable service is defined as a service that can be scheduled by a healthcare consumer in advance, and the hospital should select services that are commonly provided to its patients. This also needs to be prominently displayed on the web without any barrier for patients to access. On the data elements, this is something that's a bit new too. You need to have a plain language description for that primary code. So just kind of the basic kind of HCPCS description, probably not going to be sufficient. You need to have a more layman-friendly description that's a part of this. You need to show the ancillary services that the hospital would customarily provide in conjunction with that primary shoppable service. So if there are some lab tests that are typically done in conjunction with some type of a surgical procedure, supplies or drugs, so forth, those would need to be also shown in the disclosure. And then for standard charge, this is really interesting. For some reason, CMS has specified that all 5 of the standard charge definitions need to be disclosed with one exception, the gross charge. So you do not have to show or share your gross charge, that kind of the CDM charges for this particular disclosure, but you do need to show the other 4 elements. As a alternative to posting this static view of this data, CMS has said that they will deem a hospital as having met the requirement if the hospital maintains an internet-based price estimator tool that meets the following requirements: that there are still at least 300 services provided for that, including the CMS 70, that it does provide an estimate of the amount the patient will be obligated to pay. So that does not mean that it has to be the exact amount or obligates the hospital to commit to that being the price that the patient will pay, but it is an estimate. And then finally, that it is prominently displayed without any kind of fee or without having the patient register or establish a user account or password. And again, some of that presents some issues because some of the information could be sensitive that the patient would need to provide. So again, something to consider there as an alternative format. CMS did provide an illustration of what this could look like if you decided to post a static view. So here was an example for a colonoscopy. This is their patient-friendly kind of language for that. It's a primary diagnostic procedure. And then there's the HCPCS code. And then here is the standard charge, and you can see for Plan X. So this is that negotiated charge for that particular procedure. Non-compliance. CMS has now specified a penalty of up to $300 per day for any hospital that does not comply. that if you want to do the math, that amounts to $109,500 for each individual hospital that would not be compliant for an entire year. They do provide information on a process for enforcement and then also appeal within the rule as well. Kind of to conclude, we've had a number of folks reach out to us to inquire if we will be making available a solution to help hospitals comply with these two components. And we do have that offering. We've put our offering essentially into three different components. The first is a consulting component. Many questions have kind of come up in terms of the consumer shoppable and trying to position those elements potentially for disclosure, just being mindful of how those pieces might compare, or even in system settings, trying to think about do we have a consolidated list for all hospitals within the system. So again, the consulting component here can assist in developing that and also looking at kind of any financial impact to trying to modify codes such to make them kind of more competitive or positioning, again, them in an area of transparency. The second piece is that consumer the comprehensive machine readable file. Again, vast amounts of data that certainly go into that. But I know there are a number of folks that are on the call today that we partner with on those rate advisor consulting services. Again, benefit there is the information that we collect in that particular service enables us to put together that disclosure document for all 5 of those standard charges, again, with the addition of that discounted cash price policy information. The final piece then is the consumer-friendly shoppable services. And again, that piece can be met through the elements that we take in for the rate advisor consulting service, and again can also help position those 300 services through that consultative process. We will offer both the static view and then also the patient estimation tool as well for those that might need that. Kind of in general, there's 4 phases to this approach. One obviously would be to gather those different elements, the CDM, the payment information, the patient claim detail, then constructing that information into building those disclosure documents, refining any of those elements that might need to be addressed through an iterative process if, again, there are some elements in that list of 300 that need to be modified in some way, and then producing the documents for disclosure. So again, primary purpose for today's call really was to highlight the different requirements, but certainly do want to let you know that if you do need assistance in looking at any of these elements, obviously this is a key service that we've provided for years in terms of assessing this information and helping hospitals evaluate their charge position and also their payment position, and would certainly welcome any questions or comments or opportunities to partner with you as you consider these solutions going forward. So with that, I'm going to kind of wrap up here, and we wanted to make sure that today's time had plenty of opportunity if there were specific questions that you had, that we had an opportunity to address those right now. So Mike, I'll turn it over to you and see if there's any instructions for Q&A.
Yeah. So Jamie, I don't know if you can see your Q&A or chat box, but there's a few that have come through in the Q&A, and I'll get to some of those here in a minute. Or if you see one you want to address, that's fine. But let me address the most commonly asked question so far, and that is, will copy of the slides be provided? And yes, they will be. I mentioned at the beginning of this that we are recording this session, and we will post it on our website within the next couple of days. So we'll be following up via email to let you know when it's available. We'll also be sending you copies of the slides as well. So we will be sending those out. Jamie, I saw a couple of them here. One of them, I'm sorry, I'm trying to scroll through these as they're coming in here.
I'm seeing them now too, Mike. Yeah, I see this one. Our surgical codes are not hard-coded in the charge master. How should they shown in this format? That's a great question. Let me actually kind of provide some insight on that. Let's go back to this disclosure first. So on the machine-readable file, surgical codes, things like, your OR, anesthesia, recovery, kind of, charge per minute sort of fees, those you would disclose through the CDM rates. So it would be kind of, your just what the billing rate is for those different time elements. However, when we get down into the payer-specific negotiated charge, what CMS would be looking for there is what the payment rate would be for, let's say you have a case rate for those surgical procedures. They would want to know what the payment rates are for those there. That would be for that element. On CMS's colonoscopy example, it would kind of flow through similarly. Because gross charge is now not an element, at least on the consumer shoppable piece, you wouldn't have to be concerned about the charge master element there. It really would be kind of displaying what the payment is, again, after HIM would make those soft-coded assignments. So, excellent question.
Jamie, it looks like I saw one here regarding in the chat under kind of auditing of, where was that? I'm sorry, here I just had it. Oh, has anyone heard anything about how or if this information will be audited?
Yeah, that's a great question too. No, it's not in the final rule now. CMS has just kind of laid out the process for enforcement, and I think there's not a prescribed entity for who would be going out to check, but they have given themselves essentially license to be able to do that, and if they deem that you are not compliant, that's where they could, leverage those fees. So I also see another component of that. One could argue that percentage charge contracts have zero consideration for DRGs and HCPCS codes. You're right. In a POC-based contract, essentially what they would want to see here on the payer-specific would be what that fee would be based on the POC-based payment methodology. So if your diagnostic colonoscopy has a charge of $1,000 and you happen to be paid 75% of billed charges, then your standard charge essentially would be $750 for that item in that example.
If you have an organization that has multiple hospitals, does the penalty apply to each hospital?
Yeah, that's the way that it's written. Is they have the ability to do that by hospital. So there has been some questions around in a system though. If all let's say you've got 3 hospitals in the system and all of your CDM prices are shared, all of your contracts are shared, so that truly it looks like one entity. You likely, again, in interpretation of the rule as it's written, you could create essentially either one consolidated file that would be posted on each hospital's website, or if it's a consolidated system website, you could have that down there. And again, just note that that document would apply for those 3 different hospitals. And again, in the reading of the rule as it exists today, I think that would be perfectly acceptable. Again, in that situation where all of the payment terms, all of the prices are, exactly shared. The only caveat to that could be in the DRG kind of disclosure, and then again, this goes back to really last year's disclosure document where they want average charges, just list charges, those gross price charges by hospital. That there probably could be an argument made that should still be disclosed by campus. But all of the other elements that we've discussed today, again, I think it would be very reasonable to have in one consolidated file. Does the machine-readable file need to include all pharmacy and supply charges? Yes. They have called out that specifically, that drugs and supplies do need to be included. So one of the things that we've commented back to CMS is potentially some of the challenge in displaying payer-specific negotiated charges for some of those elements, as they might be cost basis or so forth. And again, I think at a minimum, what they would be hoping for is if your provision is cost times WAC or cost times AWP or something of that nature, they'd want the language kind of spelled out, in that document. So. An interesting one here too. Is there any talk of consumers using this to shop for insurance plans? I don't know that I've seen that for this particular one, but there is obviously the rule on the insurer side where they are supposed to be disclosing payment-related information. And, I think the goal is for this to be more consumer-facing, that this information will start to be utilized through, IT kind of developers that will sift through all of this and help essentially kind of disrupt the industry in providing a new way for people to, look at and shop for information. So again, I think many of us that obviously are practitioners in this understand some of the inherent challenges to all of this information essentially trying to come together in a meaningful place, because again, one of the things we've tried to mention back to CMS is, payment is at the claim level, not at an individual item level, really for most hospitals. And so as that's the case, payment is variable by claim. So trying to help patients understand some of that information, really that needs to be kind of considered. If we just put out kind of here's our DRG base rate, it doesn't factor in any kind of utilization information. It doesn't factor into any kind of complications that could impact that base rate and so forth. Carve-outs, thresholds, outliers, lesser of, all of those things that, again, patients, they're not going to have an understanding of how those detailed elements will feed into that. Does the machine-readable file need to include employed physician fees? It does. That would be the professional kind of element that's in there. But again, one of the questions back is, well, gosh, does that? How does that employment look? Is it, if it's a separate legal entity, but we do the billing, does that count? And again, we're not attorneys, so I don't want to provide any kind of feedback there in particular. But I do think that it's very advisable to have your counsel kind of weigh in on this, because I personally believe, based on how the rule is written, that there's some ambiguity there in terms of what the employment relationships need or should look like in order to necessitate you having to disclose that. I think, again, anecdotally, some of the feedback that I've been hearing is many hospitals, in terms of the way that they employ them, believe that they might not have to disclose that because they really are not directly employed through the hospital itself. It really is a separate entity that does that. Can payer-specific information be limited to top contracts? Gosh, this is a fantastic question too. I do think that this could be a part that is in the responses to frequently asked questions. There is not anything right now that specifies any kind of volume rule. Here are some rules of thumb that I think are supported from the rule itself. We know right from the rule that it says it's negotiated. So if you are not negotiating that contract, you would not need to disclose it. So let's say you've got some out-of-state kind of plans that are trying to kind of maybe utilize or leverage an existing contract at the hospital. Again, because you've not negotiated individually with that group that is utilizing potentially a contract there. Let's think of an example like a Blue Cross, and the Blue Cross of a separate state is trying to utilize the contract that exists for you in your state. Again, that to me would not be required for you to draw out all of those different instances because A, you would be showing the source contract, but B, you don't directly negotiate with that payer. So that's one thing that I think is very easily supported from the rules language. The other would be if you did not have volume potentially, so let's say it's an older contract, I do think there's something to be said for activity here. If it's not an active contract, I don't think that would be one that you would have to disclose. But again, beyond some specific volume threshold of it has to be X number, I am guessing that CMS probably would come back and say, you need to disclose by default.
Jamie, here's one that came through chat. Actually, we're getting quite a few questions here. So, and I know we're going to be running close to our hour here soon. So what I might suggest is, in addition to emailing copies of the slides and letting you all know when the recording is available on our website, we'll put together kind of a frequently asked questions document and try to summarize some of the comments and questions that we're getting, because we're getting a lot of great questions from you guys. So we really appreciate that. And I don't think we're going to be able to get through them all, but we'll try to summarize them in a document and get them out to everyone. One that came through, in case we missed it here, Jamie, was, has CMS released information about naming conventions for these files or preferred ways that they're stored or housed on websites?
Yeah, they have. In fact, in their examples, this is the naming convention that they want on there. So it's really not anything too significant, but they just want to make sure that probably there's some level of consistency that's there. So, the hospital, prices posted and effective of that date, probably again, so version control, they would know the last point that it had been updated. They do the same here on their disclosure here. You can see the same exact one is located up here. Great, that's a great question too. Trying to see if there's any more that, as I scan through. Okay, here's a new one. And what detail level do we need to post payer negotiated charges? We have multiple contracts for one payer. For Aetna, let's say you've got an HMO and a PPO. They want to see the rates for the HMO and the PPO. So you're exactly right. This certainly expands out the number of kind of plans that you need to provide. One of the things that has come up though that just to kind of carry off of that, all of the payer components of that. So let's say you've got an Aetna you've got an Aetna HMO and PPO, but within Aetna has a number of different sort of supporting group plans, if you will. You would not need to disclose all of those. That would not be a burden that you'd have to go through. It's really what are the source rates that you are negotiating with them? And then from that, they may have, different products essentially that obviously have copays, deductibles, and so forth. You don't need to disclose all of that additional information. That would not be a burden that would be on your shoulders. So I wanted to at least specify that. But it would be, for the HMO and the PPO, you would need to disclose that information. Great question. Looking here, it sounds like payer-specific charges need to be included in two places. One, the list of standard charges, and two, the list of shoppable services. Yes, and really the thing that, just to clarify, the list of standard charges, really the way that CMS is describing this is the formats are their machine-readable file and the consumer shoppable file. So their definitions of standard charge, right here, these 5, these apply for the machine-readable file, and then also for the consumer shoppable. The only exception is for the consumer shoppable, you don't need to have the gross charge. Is there anything in the rule that would deter us from locking the cells of our CSV files to prevent tampering or changing items within the files loaded to our website? Gosh, I'd love that question. Yeah, no, I don't think so. So yeah, I think that makes complete sense, actually, that you, and again, that's probably a great piece for the IT folks, that nothing is altered in any way. I think that's a great security kind of feature in there. It would need to be read, essentially kind of, downloaded and read, but yeah, you'd absolutely want to make sure that they weren't tampering with those. So I don't know that I've actually seen that question before, so great comment there, and that certainly would be one for the IT folks to consider.
Got one here that came through chat. Jamie, I know we've got a couple minutes left, though. Has anyone discussed how to best lay out bundled pricing in regards to transplant services? Something that has different rate structures across care phases.
Yeah, this is really good, and actually in some ways could be applied even more broadly. If I'm interpreting the question correctly, let's consider the definition for of a DRG or some case category, right? Thinking very simplistically, the way that one payer might define a bundle or an aggregation, sort of this, we come here, this service package, even though the terminology might be very similar, again, it might be a DRG, it might be some type of a surgical case or something of that nature, or again, or a bundle for a transplant bundle or something of that nature. What we find, right, is that definition, while the wording might be the same, the components of it could be different by each payer. And so again, one of the questions that we had back to CMS is it very well could be that on your de-identified min and max, that really the de-identified min and max might be a massive document, because every payer's rates could actually be its min and max, because the way that they define that service could be unique to that particular payer. And again, I think the thought going into it was that there would be a lot more consistency, and in reality, the way that these contracts are structured is that they can be very unique, obviously, in the way that they're defining these services. So, we've proposed that back, and again, I think when I have had a phone conversation too with them, I think they recognize that very well could be the case. I hope that answers the question. Again, that's the way that I was kind of interpreting it, but certainly if not, please let me know.
Yeah, and excuse me, as I mentioned earlier, it looks like we're running close on time here. So what we'll do is we'll follow up with everyone in the next few days to let you know when the recording of this webinar is posted and available on our website. We'll also be sending you copies of today's slides so that you have them for reference. And we'll put together a kind of frequently asked questions follow-up. You guys had a lot of great questions, and unfortunately we couldn't get to all of them, but it looks like there's some overlap in some of the topics, so we'll try to consolidate these and put together a frequently asked questions document to send out as well. So again, Jamie, did you have any last minute thoughts or comments before we wrap this up?
No, I just echo your feedback too, Mike. I mean, again, we can't thank you enough for making time for this today and the fantastic questions that have come in. So, you know, there's a phrase, we're all in this together, that's going around right now, given the environment that we're in, and we certainly kind of apply it here as well, that, you know, if there's any way that we can support you or help answer additional questions in any way, please let us know. So thanks again.
Great. Thanks, Jamie. And thank you to everyone who participated today. And we'll be in touch with you all in the next couple of days with all of this information. So hope you have a great day. Take care and stay safe. Talk to you later.